Piriformis Syndrome. Piriformis syndrome is essentially a condition when the sciatic nerve is getting compressed by a muscle. In this case, it's called piriform muscle, which runs from the sacrum to the greater trochanter of the femur. This is located in the posterior aspect of the buttocks region. And underlying this muscle, the sciatic nerve runs from the spine down into your leg, directly beneath the muscle. Therefore, any tension, spasms, or hypertrophy of this muscle, the piriformis muscle, may cause compression to the sciatic nerve, causing symptoms such as buttocks pain that may radiate down your leg. The diagnosis of this condition is mainly clinical, meaning involving entirely history taking, and physical examination of the patient. The physical examination of the patient itself, there are some tests that you can perform to help you identify this condition, namely Freiberg test, pace test, Beatty test, and fear test. Fear test is also sometimes used interchangeably with Fader test. They are both the same thing under different names. We will talk more about them later. The diagnostic workup that you can do, such as MRI and electromyography, can help you to exclude other possible causes. This condition is sometimes misdiagnosed as other pathologies such as lumbar disc herniation and other lumbar pathologies that may cause compression to the sciatic nerve because of the symptoms overlap. A lot of these conditions have radiating pain that goes down to your leg. And for the management itself is principally similar when dealing with other conditions. It starts from the safest approach that is the least damaging to the patient's tissue, namely conservative management, which include, in this case, physical therapy that focus on strengthening and stretching the piriform muscle itself, core stabilization, hip stabilization, and also pharmacological intervention when necessary. These modalities have been proven to provide relief of pain in this condition. However, the response is variable from one person to another. The pharmacological intervention that you can apply include such as non-steroidal anti-inflammatory drugs or muscle relaxants. When appropriate attempt at conservative management have been performed, yet it only produces little to no result, invasive approach can then be considered, which include corticosteroid injection, usually performed diagnostically, that is, to diagnose the condition itself. It sometimes is performed at the first meeting at the office, but it is performed under imaging, usually ultrasound, where the needle is then guided to the piriform muscle under ultrasound guidance, and then corticosteroids injected into the muscle. If there's temporary relief of the pain, that essentially confirms that there is a piriform muscle pathology being the source of the pain, which is then followed by botulinum toxin injection into the muscle to provide a more long-term, more sustained relief of pain. So, as we have mentioned before, Piriformis syndrome is basically a condition that involves the neuron and the muscle, in this case the sciatic nerve, being irritated by pressure from the piriformis muscle. The function of the piriformis muscle itself is external rotation and abduction of the hip. And tightness, spasm, or anatomical variations may produce a higher likelihood of this piriformis syndrome occurring in a patient. These anatomical variations include a split piriform muscle where instead of being a one thick muscle band, it is actually multiple bands between which the sciatic nerve runs through, which increases the likelihood of the nerve getting impinged whenever the muscle experiences excessive tension, spasm, or hypertrophy. And when this occurs, the manifestation include buttocks pain that may radiate down the leg. The diagnosis is mainly clinical. The Freiberg test, for example, that you can do during a physical examination, pace test, Beatty test, and fear test. Fear itself is an abbreviation for flexion, adduction, internal rotation test. And then diagnostic workup that you can do, although not routinely, because this is a clinical diagnosis most of the time, meaning you don't need diagnostic workup to diagnose this, include MRI and electromyography. And these tests are also not very sensitive nor specific for Piriformis syndrome, because Piriformis syndrome is mainly a functional muscular condition that does not need to involve the presence of a deformity of the spine, nor the muscle itself to occur, unlike lumbar disc herniation, where on MRI it will be revealed that there is a lumbar disc herniation. But in this case, Piriformis syndrome can be totally normal under imaging or even under electromyography, yet still occurring. So it's neither sensitive nor specific for the Piriformis syndrome. That is why diagnostic workup is mainly to exclude other possible diagnoses when you are still unsure or suspecting other causes of the pain. There's also a lack of definite optimal diagnostic criteria for the syndrome. Hence, it is sometimes a diagnosis of exclusion, meaning it is something that is diagnosed once other causes of the pain has been excluded. But this is very time consuming and resource consuming, because sometimes for excluding other diagnoses you would need diagnostic workup such as MRI, which are not affordable in most cases. The management, again, conservative. When conservative fails, invasive can be considered, including injection of certain agent that relieves pain, such as steroids, in this case corticosteroids, or muscle paralytic agents such as botulinum toxin. The steroid injection usually is performed diagnostically because it only provides temporary relief of pain, yet botulinum toxin injection is one that provides a more long-term, more sustained relief of pain. When these fails, surgery can be considered. In this study that we referenced earlier, they are discussing a case report of a patient suffering from Piriformis syndrome that does not respond to initial therapy. A 62-year-old woman with no trauma history, with 10-month history of left buttocks pain, with a pain scale of 5 out of 10. This pain exacerbated in sitting position and supine position, and there is paresthesia in the posterior aspect of the knee in the same side or ipsilateral, especially when the patient is seated. Previous treatments that the patient has undergone include betamethasone injection to the gluteus maximus muscle. Notice it is not the piriform muscle that she was getting treated for. She has also undergone physiotherapy, but these provide no significant improvement in her manifestations. Upon examinations, inspection in this case, visual inspection, it was revealed that there were no spinal deformity and her gait was normal without any signs that points to a gait pain elicited during walking. None of that. During palpation and percussion, deep palpation and percussion of the spinous processes of the vertebrae reveals no tenderness or pain. Deep palpation of the perivertebral muscles also produces no pain or tenderness. However, deep palpation of the piriformis muscle in the buttocks region produces the same symptom that she was complaining about. It produces tenderness or pain in the buttocks. Palpation of the greater trochanter of the femur bone produces no tenderness. This also helps us exclude conditions such as trochanter bursitis and gluteal tendinopathy. Trochanter bursitis is inflammation of the bursal sac of the greater trochanter of the femur. Gluteal tendinopathy, as the name implies, it's anything that irritates or inflames the tendon of the gluteal muscles. Clinical tests that has been performed on this patient include ipsilateral Freiberg test, which is passive hip internal rotation while the knee is extended. In fair test, itself elicited the similar buttocks bend along with the ipsilateral Freiberg test as well. This supports the diagnosis of Piriformis syndrome even more. And then ipsilateral LASIK and Brochado test was also performed. These tests are normally performed to seek out any irritation of the sciatic nerve, whatever the cause. And this also turns out positive, which is in line with the pathophysiology of this condition. An irritated or inflamed sciatic nerve and tension of the piriform muscle. And there were also tenderness during depalpation of the piriform muscle, and these supports the diagnosis of Piriformis syndrome. Upon imaging with MRI, it also shows enlarged left piriform muscle. It does not have to show this, but it does. Meanwhile, there were no clue that points to other possible causes of this buttocks radiating pain, such as disc herniation, etc. It was not present. EMG shows chronic neurogenic atrophy of the muscles innervated by L5 myotome, and this is one of the root that contributes to the sciatic nerve. This points to a problem in the L5 nerve root that comes out of the spinal cord and is also part, again, of the sciatic nerve. On the right image, you can see a cadaveric visualization of the sciatic nerve and surrounding structures. Gmax refers to gluteus maximus muscle, GM gluteus medius, GT to the greater trochanter of the femur bone, QF or quadratus femoris, SN is sciaticus nerve or sciatic nerve in English, P is the piriform muscle, the stick band. Sometimes in anatomical variations, it does not show as one intact band, but instead two bands that pinches the sciatic nerve, which increases the likelihood of Piriformis syndrome to occur. And then the OI is the oblique internus muscle. STL is sacrotuberous ligament, which extends from the sacrum bone, which is the bone above the tailbone, to the ischium tuberosity, which is not visible here. And then the patient underwent a ultrasound-guided corticosteroid injection to the piriformis muscle, and immediately a relief of pain was noted. This is a proof that the pain source originates from the piriformis muscle, meaning it essentially confirms that there is a problem in the piriformis muscle being the source of the pain. Therefore, it is then followed by injection of botulinum toxin into the same piriformis muscle. This provides longer term and more sustained relief of pain. Physiotherapy was also initiated again in this patient that mainly focused on strengthening and stretching of the piriform muscle, hip stability, and core stability to help ease the pain. 4 weeks after follow-up, the pain scale reportedly goes down from 5 to 1, and further follow-up reveals that the patient has become asymptomatic and remains so afterwards. These two are images of the ultrasound of the patient. The left one depicts the cross-section anatomy based on a 2D ultrasound of the buttocks region. As you can see, the top layer, the skin, directly beneath the skin, SCT refers to subcutaneous tissue, which is filled with fat. And below that is the gluteus maximus muscle, a thick layer of muscle tissue. And below that is the piriformis muscle, the PM. And under that runs a rather thick isoechoic sciatic nerve, which really shows how likely it is, as in explains why it is likely for the piriformis muscle to cause sciatic nerve issues due to the proximity of the piriformis muscle with the sciatic nerve. And underlying the sciatic nerve is the ilium bone. On the right is the ultrasound visualization of US or ultrasound guided injection into the piriformis muscle, where the arrowheads, the multiple arrowheads, shows the needle that goes into the piriformis muscle, and the white arrow points to the tip of the needle that goes into the piriformis muscle. So we can review a little bit of what we have gathered so far. Piriformis syndrome is basically a neuromuscular condition involving sciatic neuropathy secondary to compression by a piriformis muscle pathology. Sometimes it includes tension, spasm, or hypertrophy that cause impingement on the nerve. And this causes symptoms that is usually in the form of buttocks pain that radiates down into the leg. It may be challenging to diagnose because currently it has many overlapping conditions that shares this symptom, and the fact that there is no optimal diagnostic criteria that has been established to this day. It is also important to note that some people may have a higher propensity to develop this syndrome due to anatomical variations, such as split piriform muscle or the sciatic nerve itself that runs through the muscle, despite whether the muscle is split or singular. Conservative management involves physical therapy that focuses on stretching and strengthening of the piriformis muscle, core stability and hip stability, and analgesic or pain medications such as NSAIDs, non-steroidal anti-inflammatory drugs, and or muscle relaxants. They have been proven to provide pain relief as well in this condition. If conservative treatment fails or does not produce significant result, again, invasive approach is then considered, such as corticosteroid injection into the piriformis muscle under guidance, followed by botulinum toxin when it is confirmed. And the current limitations that we have about this piriformis syndrome is that we lack, again, optimum definite diagnostic criteria, and that there is variability, a significant variability of response to treatment between one person and the other. This points to a possibility that there may be significant differences in how this disease or condition manifests in one person to the other. Therefore, there is still a lot of room for improving personalized treatment for each patient. Thank you for watching.